Good evening, everyone. I'm Aline Sharabadi. On behalf of Monday Night IBD and CME Outfitters, I would like to welcome you and thank you for joining us for today's Monday Night IBD live webinar. Our goal today is to identify the factors that impact success in your practice taking care of patients with IBD. Today's activity is brought to you by Monday Night IBD and CME Outfitters, an award-winning accredited provider of CME for clinicians worldwide. Today's CME and CE activities are also eligible for ABIM mock points. So make sure you engage in today's event, answer poll questions, submit your questions, and provide your feedback. Once you complete today's program, be sure to provide your ABIM ID and birthday in the evaluation. CME Outfitters will submit your mock points. Welcome to our Monday Night IBD viewers on Twitter. So happy to connect with you again on multiple platforms. Throughout this webinar, we will share clinical vignettes inspired from real-life practice. Again, I'm Aline Sharabadi. I'm the clinical director of the GI division and director of the IBD Center at Johns Hopkins Sibley Memorial Hospital in Washington, D.C. And it is my pleasure to be joined tonight by Dr. Christina Ha. Dr. Ha is an associate professor of medicine, Inflammatory Bowel Disease Center at Cedars-Sinai Medical Center in LA. Tina, welcome.
Thanks for having me.
It's a pleasure to have you. All right. So let's start with our learning objective. Our goal today is to apply efficacy and safety data to optimize therapy selection for patients with IBD. And our second learning objective is to identify appropriate treatment strategies for special population with IBD, such as young patient and patient of racial and ethnic minorities. And finally, our third objective is to develop strategies such as disease monitoring, shared decision-making, and patient education in order to achieve optimal patient outcomes. For those of you who are not familiar with Monday Night IBD, which is the inspiration behind this program, let me tell you a little bit about it. Twitter has established itself as a fantastic way for physicians and clinicians to share medical information, key scientific papers, and lesson learned from major GI meetings, and also to share their own expertise. Monday Night IBD is a handle that was created a little bit more than a year ago to promote discussion between clinicians around challenging IBD cases. So every Monday, an IBD expert posts a clinical vignette followed by what would you do type of poll. There's no right or wrong answer. The discussion really highlights the different opinions that expert and gastroenterologists and surgeons and nutritionists and psychiatrists, all patients involved in IBD care, how they would approach the same problem from different angles and really help us tackle the clinical challenge that we have in our daily practice when there's no clear guideline or data. So everyone is welcome to that forum. Fellows, private practice, academician, and it's a really nice international platform. So this is really to show you how it works. We start our Saturday with what we call a IBD tutorial or back to basic tutorial, where we review basic information about one of the IBD concept. For example, this tutorial was about PSC and ulcerative colitis. How do we diagnose PSC? How do we monitor for malignancy associated with PSC? How UC with PSC differ from UC without PSC, etc. That's on Saturday, our back to basic tutorial. On Monday, we address a more challenging case related to that. So this was, for example, a case of patient with PSC cirrhosis with a severe UC flare-up, not responding to infliximab. What would you do next? What's the best surgery? How do we optimize this patient? How do we assess the risk of mortality with surgery versus more immunosuppressive therapy? And then at the end of the week, we put out a what we call an IBD algorithm. It's a summary of the conversation with a summary of the data that we have out there that you can save on your phone or your computer for future reference. And it's a nice way to really put all this conversation and the data we have available on that topic in one PowerPoint slide. And we really have fantastic experts in IBD participating in Monday Night IBD, and each of them tackling a topic of their expertise, whether it's pouchitis refractory to antibiotic, how to manage postoperative Crohn's recurrence, how to manage IBD in the pregnant women, adolescent medicine, how to interpret MMR serology in patients starting immunosuppressive therapy. We even recently had a conversation only in Spanish, that was actually led by our Spanish colleague during a Spanish GI meeting during Hispanic Heritage Month. So it's a very international community where everybody is welcome. We have wonderful IBD experts from different institutions sharing their expertise. So I hope you can join us on next Monday. All right, so let's start our program tonight. And Tina, I think we all agree that 2020 has been quite a year with COVID-19 and how it's changed and affected our lives. But also it's been a year where our awareness of racial and ethnic disparities in healthcare has grown related to issues of access, treatment, and vulnerability, especially with COVID. And I'd like to begin tonight discussing how these disparities manifest in the management of IBD. We posted a couple of polls on Monday Night IBD Twitter handle, and I'd like to share this poll with you, and I'd like to invite the audience to participate in this poll, please. So our first poll, which of the following statement is true? The incidence of IBD in the United States is stable and most prevalent among whites. The incidence of IBD in the US is increasing, with the most significant increase in non-whites. The incidence of IBD in the US is increasing, with the most significant increase in whites. Finally, there are a wide racial and ethnic difference in the phenotype of IBD. So please take a few seconds here and take the poll. All right, so this is the poll we have that we had on Twitter. And most people felt or were aware that the incidence of IBD is significant in minority and has been increasing in recent years. So we'll see what our audience shows. So our Twitter audience and our live audience seem to be in agreement with this assessment. So I'm going to start tonight, following this poll about the incidence of IBD in minority and what that means. There's definitely an increase in the incidence of IBD in the United States. And we still have more new IBD cases per year in whites compared to non-whites. But the rate at which this increase is happening at a much higher amplitude in non-whites versus whites. So 135% increase in non-white in the last 40 years versus 39% increase in whites in IBD. And it's important to remember that by 2050, so in the very near future, up to half of the US population will be made of minorities, mainly Hispanic and African American. So it is very important for us as a medical community, researcher, clinician, to really look whether or not there are potential differences in disease characteristics, natural history, and treatment response. What we do know now is that there's definitely a difference in healthcare utilization, and there are many barriers to care for patients with minorities. And it's important for us to be aware of that so we can improve access to care for IBD patients of all races and ethnicities. I want to share with you a few studies looking at that and looking at how minorities with IBD utilize healthcare a little bit differently. To your left, you have a graph looking at hospitalization, and there's definitely a disproportionate rate of hospitalization in Black patients with IBD compared to white and Hispanic. And on the other hand, Blacks and Hispanic have a higher utilization of steroids compared to whites. So the question can be, well, is it because Black and Hispanic have a more aggressive disease phenotype? They need to be hospitalized more often, they need more steroid. I don't think the answer is in difference in phenotype. It's more a difference in access to care and socioeconomic status. If you look at the bottom row of this slide and looking at the Medicaid insurance, you'll see that having Medicaid is associated with a higher risk of using steroids compared to having private insurance. And in other studies, Medicaid and low socioeconomic status were associated with higher steroid use, higher use of urgent care like the ER, and being hospitalized, and also higher incidence of inpatient mortality. So even though Medicaid can really help with the cost and cover some costs, the low socioeconomic factors really impact engagement in IBD care and continuity of care and appropriate care. And our patients who are underinsured or who have high healthcare costs, who are losing insurance or being in transition between insurance and have inconsistent access, have increased visit to the ER department, urgent care, hospitalization, and at the end of the day, all this leads to an increase in IBD-related disability. So I would like to know now, how does your practice look in terms of IBD and what kind of patient we are seeing in your practice? And we talked about the numbers of increasing incidence of IBD in minorities. Do you see that in your practice? So our poll goes, which of the following best reflects your IBD practice? The demographics of my practice have not changed very much in the past 5 years, and most, if not all, of my IBD patients are white. 2, the number of African American, Blacks, or Hispanic patients with IBD is growing in my practice. 3, I have a diverse population in my practice, but I'm not sure I can apply the data from randomized controlled trial to non-white patients. So Tina, as our audience is taking that poll, I would like to turn to you and ask you how, I like this last answer. You know, I have a diverse population, but I'm not sure how to apply what I see in randomized controlled trial for therapies or data about IBD patient that where the main demographics has been white patients.
Yeah, I mean, I think it's actually very challenging because if you look at the clinical trial data, the vast majority of the participants are actually white. So the question is, just like it is with any other comorbid conditions, elderly, how do we extrapolate, or can we extrapolate that data to a very diverse patient population? And I'll say in my practice, I am seeing a lot more diversity, but we're also seeing diversity in terms of, you know, at what stage in their disease they're presenting. So I think it actually falls into various buckets. First is recognizing that Crohn's disease and ulcerative colitis can be diagnosed regardless of what your ethnic background is. It isn't just a Jewish condition. But I also think part of it is understanding truly what the natural history is, because although we presume that it is similar to the white populations, there needs to be far more studies. And as you and I know, there are a lot of people who are very interested in this and want to explore this further, such as my colleague, Dr. Dermot McGovern at Cedars, and he's actually participating in a lot of multi-center collaborative studies trying to understand genetics and natural history. And with that, we have to also encourage access to treatment and really make it accessible to use all of these practice standards, regardless of what the ethnicity is. So it really has to be democratic, our treatment.
I can't agree more. All right, so this is our audience. So our audience is seeing a more diverse population, and like you, Tina, they're wondering how can we apply what we know from the data now to our non-white patients. So absolutely highlighting the need for more studies into how IBD behaves and what kind of therapy we need and what are the genetics behind IBD and risk factor in our minority population versus whites. And definitely up to a quarter of our respondents here see that their patient demographic has been changing in the last 5 years. This is excellent. So we'll start. I think I'm going to hand it to you, Tina, at this point. Let's see. Yes.
All right. So thank you, Aline. This is very exciting and already a lot of fun. So let's dive into our first case. So this is Cecily, and she's a 21-year-old African-American woman, and she's been having symptoms for the last 3 weeks. They include intense abdominal pain, followed by urgent bloody diarrhea, up to 10 bowel movements a day. And she also describes abdominal pain and distension that's relieved with vomiting. She also reports new onset joint pains involving the knees and the ankles, as well as some lower back pain or mid-back pain that's particularly stiff in the morning. Over the past 3 weeks, she's lost 15 pounds due to a poor appetite, and overall, she's feeling pretty fatigued. In terms of other relevant history, she smokes e-cigarettes, just like a lot of the other young folks are doing nowadays. I can say that because I'm no longer young. And on physical exam, it stinks to age, but it's very important to study. On her physical exam, she has a notable tenderness to palpation in her right lower quadrant, and you can tell that her left ankle is slightly swollen and tender. With basic laboratory data, we know that her C. difficile is negative, her stool cultures are negative, but her C-reactive protein is elevated at 10. So she gets a colonoscopy, and endoscopically, the TI is noted to have deep mucosal ulcerations with cobblestoning, as well as an ulcerated and stenotic ileocecal valve. Throughout her colon, she has scattered, deep, almost punched out looking ulcers, and the path shows features of chronic and severe active ileitis and colitis without any viral inclusions present. So at this point, I'd like to ask the audience, we'd like to hear your opinion about this patient. We'll revisit this question later, but we'd like to vote. How would you treat Cecily? Would you start her on azathioprine, an anti-TNF, ustekinumab, vedolizumab, or you're not quite sure yet, but you know that she needs to be on something? All right, so at this point, we need to discuss what some of the risk factors are to actually help us with our decision-making when it comes to treatment of Crohn's disease. So there's two different aspects that we have to consider. We have to consider disease activity, which is clinically how the person is feeling today or when they're in your office, versus disease severity, which is the likelihood their Crohn's disease is going to progress over time. So risk factors for poor outcomes, which is disease severity, are important to assess when you're meeting a patient to decide what their treatment should be. So some of the risk factors for poor outcomes are young age at diagnosis, less than 30, extensive colitis, ileal or ileocolonic involvement, perianal or severe rectal disease, the presence of deep ulcers on colonoscopy, a prior history of surgery, or evidence of what's called B2 or B3 disease, stenotic or penetrating disease, and a smoking history. So if we think about Cecily, she's 21, so she has that first risk factor, young age of diagnosis. She has ileocolonic involvement with deep punched out ulcers throughout her entire colon, as well as a cobblestoned and deeply ulcerated terminal ileum. So that meets three more criteria. She doesn't have any perianal disease yet. However, there is an increased likelihood of perianal disease amongst African Americans, so it's something that we have to worry about down the road without early intervention. She hasn't had a surgery yet, but she does have a stenosis that was commented on her initial history. And even though she doesn't smoke cigarettes, she smokes e-cigarettes, so the true risk of that remains to be seen. So now we know that Cecily has multiple risk factors for poor outcomes. So she has moderate to severe disease severity. And clinically, she's quite active. She has 10 bloody bowel movements a day, abdominal pain, obstructive symptoms, extraintestinal manifestations, as well as weight loss and an elevated C-reactive protein. So now we know we need to treat her with an agent that's appropriate for moderate to severe disease. And according to our recent evidence-based guidelines, we have to remember that oral corticosteroids in the setting of Crohn's disease are only induction therapies. They're not meant for maintenance. So as soon as we start a patient on corticosteroids, we have to start thinking about what our steroid-sparing agent is. And in 2020, we are lucky in the sense that we have multiple options, such as thiopurines and methotrexate, although it's debatable for this type of patient if we're going to use it as monotherapy. A lot of it has to do with access. Or we can use anti-TNFs as monotherapy or in combination with an immunomodulator or methotrexate, vedolizumab, and ustekinumab. And as we'll talk about later on, we also have multiple other MOAs or mechanisms of action in the horizon. So we have to start positioning our agents relative to disease activity and disease severity. So why is this so important? Well, this is actually data that was published earlier this year by Corey Siegel and his colleagues. And it was a retrospective observational study using administrative claims data on patients who were newly diagnosed with Crohn's disease. They looked at over 16,000 patients. And what they found was these patients who were newly diagnosed with Crohn's disease, about 42% of them were initially treated with corticosteroids, but also 35% of them were initially treated with 5-ASAs as monotherapy. And as we know, the data supporting the use for 5-ASA in Crohn's disease is actually quite poor and not evidence-driven. However, what's more disappointing and surprising, and an area we really need to improve upon, is that less than 5% of patients were initially treated with biologics. And you can say, okay, steroids as an induction therapy is reasonable. However, only 19% followed a biologic treatment pathway early on in their diagnosis, even with a course of corticosteroids, compared to 81% who followed a non-biologic treatment pathway. So there's a lot more that we have to improve upon in order to provide our patients with the appropriate evidence-based treatment. Now, what may be driving this? So there may be different perceptions of steroid use. This is actually an important study that was presented by my colleague and great friend, Anita Afzali, earlier this year at ECHO, and it was to be presented at DDW. And they did a multinational survey study of both patients and providers. And these were IBD providers who saw actually a fairly large percentage of IBD patients with moderate to severe disease activity every month. And of these patients who were surveyed, over 1,300 of them with Crohn's disease, 75% reported receiving at least one course of corticosteroids. Now we have to ask ourselves, okay, what's the difference between providers and patients' perceptions of steroid use? So physicians and patients both reported similarly that about 35 to 40% of patients took steroids for at least 4 months or more, or even 6 months or more during the past year. However, what's really important is the different perceptions about, is that okay to be on steroids for that long? Only 27% of the physicians were really that concerned about the steroid use, and half were concerned about being on it for a prolonged course of more than 4 months. Whereas from the patient perspective, almost 50% of them were concerned about being on steroids, and over 2/3 wanted to stop the steroids as soon as their disease was under control. And knowing that steroids are only used for induction, this means we have to choose an appropriate maintenance strategy, steroid-sparing maintenance strategy, so that they don't need repeated courses of steroids. So which one to choose? I told you that there's multiple mechanisms of action. We have at least 3 different classes of types of biologic mechanisms that we can choose from. So this is a systematic review that was published by Sid Singh at UCSD a couple of years ago. And basically they were looking at the efficacy of the various anti-TNF, vedolizumab and ustekinumab compared to placebo. Now, it's very important, you have to be cautious about applying these systematic reviews to practice, because at face value, it looks like the anti-TNFs, infliximab and adalimumab, are the most effective compared to placebo relative to certolizumab, vedolizumab, and ustekinumab. But my take home that I look from this chart is, everything is more effective. So you have to choose something. What's not effective is doing nothing. So this is where you have to look at the patient's perspectives, shared decision-making, their risk factors, their likelihood of progression, and choose the right agent according to the patient's needs. So the reason why it's important to start anti-TNFs early is based on multiple studies. And here's an example that's published from David Rubin a few years ago. Basically, they looked at claims data of close to 4,000 patients. And these are patients who were newly diagnosed with Crohn's disease. And they actually stratified the patients into 3 different groups. The first group actually were early initiators of anti-TNF, meaning they had their first prescription of anti-TNF within 30 days of their diagnosis. The second group actually had more of that old school step up model, where they were prescribed an immunomodulator or immunosuppressant, and then if they needed it, then they stepped up to an anti-TNF. The third group stepped up immediately from a course of corticosteroids or aminosalicylates to anti-TNFs. And as you can see from the bars, the group that started with the early anti-TNFs first, which is the solid line on the bottom, they had fewer percentages of patients with continuous use of corticosteroids at month 6, 12, 18, and 24, compared to groups that started with immunomodulators first, which was the dashed lines, or 5-ASAs and corticosteroids, which is the dotted line on top. So the take-home message is, if our patients, and over 2/3 of them in that survey from Anita Afzali's data, want to be off steroids as soon as possible, the best way to do this is to start with a biologic early on. This is additional data from this group looking at another important outcome, which is the likelihood that they're going to need Crohn's disease-related surgery. Now, the dark blue bars on the left represent the patients who started on the anti-TNFs early. And across the board, over time, at months 12, 18, and 24, the group that started anti-TNFs first were less likely to have Crohn's disease-related surgery compared to the other groups that stepped up over time. How about ER visits and hospitalizations, increased healthcare utilization? So this is a study from that was to be presented by Ryan Ungaro and the group at Mount Sinai. And again, they looked at a claims database, and they divided the groups into 2 different groups: early biologic users, which were patients who were prescribed a biologic during their first year of diagnosis, versus late biologics users who weren't prescribed biologics during that first year. And what they found was at months 12 to 24, which are the blue bars, the patients who started biologics during that first year of diagnosis had fewer hospitalizations and ER visits compared to patients who began biologics later. Again, supporting the notion that if we want to keep patients out of the hospital, off steroids, and avoid surgery, you need an early biologic strategy. So let's recap Cecily. So we have a 21-year-old African-American woman with moderate to severe GI symptoms and weight loss, potential extraintestinal manifestations with peripheral and axial joint pain. She is an e-cigarette smoker, and her colonoscopy showed moderate to severe ileocolitis with a stenotic IC valve. So, based on what we discussed, would this change how you would treat Cecily? So what are your options? Would you start her on an immunomodulator, azathioprine? Would you use anti-TNFs, ustekinumab, vedolizumab, or you're not quite sure yet? So again, you can go ahead and vote now. And I think maybe at this time, Aline and I can chat a little bit about the case.
Yes, I would love to see how, we'll see how the pre-discussion and after discussion poll, if they change, if people are still in their mindset. You know, Tina, we talk a lot about how it's important to get patients off steroids. And one of the questions we're getting here is people saying, you know, we've used steroid for a long term with success. What is the problem? Why should we get people off steroids if they feel so good on steroids?
Mm-hmm. Well, first and foremost, they're never meant to be on maintenance, and people, and I think that this comes into the part of our discussion of how we're communicating how patients are truly feeling. So if a patient is feeling good on steroids, what does that mean? Does that mean that they're able to manage their symptoms? Because very few patients really feel perfect when they're on steroids. Very few patients have a completely healed colon or complete normalization of their bowel movements or absence of bleeding. So the key is, the reason why you need to stop steroids is, out of all the agents we have to treat Crohn's disease or ulcerative colitis, by far the greatest risk of complications is with chronic corticosteroid use. Infections, hospitalizations, postoperative complications, compounded with malnutrition if you're not on a steroid-sparing agent. And also in the setting of, you know, COVID-19 infection right now, we need to get our patients onto something that's safer.
Absolutely, I agree. It's the least effective choice for maintenance. It really has many side effects. And when we worried about potential side effects with biologic and immunomodulator, we worry really about the risk of infection. Mm-hmm. And many studies have shown that steroids actually really increase the risk of infection. The TREAT registry, looking at patients with IBD on infliximab, on steroid and narcotics, etc. The worst combination was steroid and narcotic, really increasing the risk of infection, and definitely steroid increased the risk of morbidity and mortality. And there was a recent actually data by Jim Lewis looking at morbidity and mortality, comparing anti-TNF and patients who were on recurrent steroid or maintenance steroids. And those who were on steroids had definitely higher mortality, higher MIs and strokes. And one of the things that to remember is that this inflammatory process is not just in the gut. And now we're realizing that really affect the whole body, including increasing cardiovascular incident and disease. And in that data, actually, it was very clear that even the patients with comorbidity or older patients did better on biologic, on anti-TNF than they did on steroids. So our goal is always to minimize steroid use and use steroid sparing therapy that are effective. All right, so we have our poll result here. So 12 people started wanting to use azathioprine, and I think, you know, you did a good job at making them change their mind. Azathioprine is still widely used. However, you know, you showed very nice data showing that early use of biologic is really what get patient off steroid as opposed to using azathioprine. And azathioprine is associated with a higher risk of infection and a potential risk of lymphoma in certain population, mainly young men and older men. Then we had most people were going for anti-TNF before we started the discussion, and they, you know, around 50 to 60% now will go for anti-TNF, and fewer will choose vedolizumab or ustekinumab, and a small percentage still is not sure. So I guess that'll give us incentive to keep on going and talking about more option. But Tina, I want to get back to our patient. You know, I think you mentioned when we look at the patient with IBD, it's important not to only focus on the GI symptom, but really look also for extraintestinal manifestation of their disease and their social history. You mentioned e-cigarette smoking, and smoking cessation is absolutely important to recommend and encourage at every visit. We all know that smoking is very hard to give up. So it's important to encourage the patient, but also put them in a program and work with their primary care doctor to stop smoking, because cigarette smoking really increases the risk of disease complication, needing surgery, and not responding well to therapy. But also, we talked about her having joint pain and joint swelling. Would that, make you choose one therapy versus the other for her Crohn's?
Yeah, so it would and wouldn't first, because it depends on how certain we are that the joint pains aren't related to disease activity versus independent. So if she were just having the knee and ankle pain, I would say, you know what, the most important thing is we have to get her on a steroid sparing agent, because it's really the inflammation that's driving her joint pain. But the key other aspect of her symptoms is she was also describing some back pain. And the back pain makes me start to think, could she possibly have ankylosing spondylitis? And not all of our biologics actually have efficacy for ankylosing spondylitis. The anti-TNFs do. And we also know from various natural history studies that she may be, particularly if she has deep ulcers throughout her colon, potentially even involving her rectum, be at greater risk for perianal disease too. So we want an agent that works to cover both her luminal as well as her extraintestinal manifestations. We want an agent that's going to work relatively quickly. And because she already has ulcerated stenosis, we also have some good randomized controlled trial data that anti-TNFs can be effective for stricturing disease, some parts of stricturing disease.
I think you and I practice very similarly. And in this young patient who's very symptomatic, has symptoms suggestive of ankylosing spondylitis, and really severe disease and ileal involvement, my first choice would be an anti-TNF. One of the things I do is, if I choose to go with infliximab, I do combine with an immunomodulator the first year, because this is really when we have a higher incidence of antibodies. If I go with adalimumab, I usually start monotherapy, and I wonder if you do the same, or how do you assess things?
Yeah, so I do for the most part do the same as well, but some of it also factors on their acceptance of the diagnosis, their likelihood that they're going to follow through with the lab tests and the adherence to the thiopurine therapy, potential risk for infection, or potentially family planning. For a woman who's 21 years old, methotrexate may not be something that I'm that keen on. And because this is a new diagnosis, sometimes it can be overwhelming beyond a lot of things. So for high-risk patients, I do tend to choose combination therapy, particularly with infliximab. But if I'm a little bit more worried about adherence or acceptance, I may start off with optimized monotherapy initially, but following definitely a treat to target strategy, which means we all have an understanding that we should expect a response within the first 12 weeks.
Absolutely. So before we go to our next patient, there's one more question that could be, you talked about the risk of perianal disease if you see, definitely if you see severe disease, and definitely if you see ulcers in the rectum. So anytime I see deep ulcers in the rectum, I know I have to be aggressive with my therapies, because that put the patient at high risk of perianal disease. So do we have data on difference in perianal disease between men and women, or by race?
So this is where we obviously need further investigation. And so, in terms of differences amongst gender, it's hard to say, because we know that up to 30% of people who are diagnosed with Crohn's disease will develop perianal disease. And part of it is recognizing early perianal disease in terms of the elephant ear skin tags, the deep fissures, before they become full-blown fistulas with complex horseshoe fistulas and abscesses. But in terms of different ethnicities, there are suggestions that certain ethnicities may be more prone to having complex perianal disease. And some studies suggest that potentially African Americans may be within that category. But this is, again, why we need more participation, greater access to participation in studies, so that we can really follow these natural histories over time.
Absolutely, couldn't agree more. That was a fantastic discussion. We have more questions coming, but probably we'll save some for next. All right, I think we're going to go to our next patient. This is Mateo. Mateo is a 33-year-old Hispanic man. He had several weeks of non-bloody bowel movement, and he actually lost a fair amount of weight, 12 pounds, and he's been very fatigued. However, he did not seek care at this point because he does not want to miss days of work, and he's the only provider for his family. But he finally presented to the emergency room because of the left lower quadrant pain and low-grade fever. In the ER, the routine labs were normal. 2 studies were sent, and the CT scan, of course, was done, showing thickening the transverse and left colon. The ER physician prescribed some antibiotic and narcotics and sent Matteo home. Matteo, come and see you, and as a wonderful gastroenterologist that you are, you take a comprehensive history that include a family history, social history, other medical problem, etc. It's very important to ask our patient how this disease is affecting their life, how the symptoms are affecting their life at many levels. So Matteo actually immigrated to the United States from Cuba 4 years ago. He is employed as a social worker and works with immigrants. And because of his fatigue, he's been missing days of work. And this is something he tells you, I just really cannot afford it right now. He's been, because of his job, he's had recent exposure to tuberculosis. However, his quantiferin gold came back indeterminate, and his chest x-ray is negative, and he's pending further workup. On physical exam, he has a moderate left lower quadrant tenderness. His albumin is holding up at 3.8, but his CRP is elevated at 10. So this is my question to you, to our audience. And we asked the same question to our Twitter audience also before we started this webinar. What is the risk of IBD in first-generation immigrants coming from countries with low incidence of IBD who now live in a country like the United States with a high incidence of IBD? A, the risk of IBD increased slightly, but remains lower than the overall US population risk. B, the risk of IBD increases to reach the same level as the USA population risk. C, the risk of IBD remains low and doesn't increase until the next generation. And D, I don't know. So most feel that the risk of IBD might increase slightly, but remain lower than the overall patient population. And another third feel that the risk of IBD increased to reach the same level as the patient population. And our Twitter poll, we had a little bit slight answer where the majority felt that the incidence of IBD in immigrants, in first generation immigrant, reaches very quickly that of the country they're immigrating to. So I'm going to start kind of to answer this poll question. I'm going to start with the study that was done by Orana Damas and Maria Abreu, looking at Cuban who immigrated to the United States before 1980 and after 1980, and their risk of IBD and the incidence of IBD. And the finding that were very interesting is that in Cuban arriving after 1980, compared to those arriving before 1980, the age of diagnosis of IBD became younger. So before 1980, the diagnosis of IBD, the mean age was 44. And in present time, it's more, the mean age is 33. So there's definitely a decrease and a younger age of IBD diagnosis. But what's even more interesting is that now there's a shorter time between immigration and the diagnosis of IBD. So before 1980, 30 years would pass between Cuban arriving to the US and then being diagnosed with IBD. And in more recent times, less than 8 years passed between immigration and the diagnosis of IBD. Overall, there was no difference in IBD phenotype, including the type of IBD, disease location, the need for surgery, but there's definitely a change in how quickly people are developing IBD, their increased risk, and developing at a younger age. And we can talk later about why this could be going on. I see some questions in the Q&A section about, is it diet, is it the microbiome, is it lifestyle, and we can discuss this later. But one point I want to make is that this is not particular to the Cuban population, and immigrants from different areas of the world where there's a low incidence of IBD coming to the US have an increase in the risk of IBD that catches up very quickly to the risk of the US population. So let's go back to Matteo. So Matteo came in with these GI symptoms and fatigue and weight loss, and we proceed with a colonoscopy, and we have deep linear ulcers throughout the transverse left colon and sigmoid with rectal sparing. And on biopsy, we have features of chronic colitis, but also severe acute colitis, and no viral inclusions were present. So how would you treat Matteo? And again, we have the same options that we discussed previously. Azathioprine, anti-TNF, ustekinumab, vedolizumab, I'm not sure. All right. So I think one of the main point here is when we're assessing our patients, in addition to asking about GI symptom and extraintestinal manifestation, is really to see how their disease is impacting their life. And Matteo made it very clear that his disease is affecting his capacity to go to work and work. And we have good data showing that active disease, patient with active disease reports limitation at work, mainly because of fatigue. So I want you to focus on the graph and on the columns on the far right. Looking, red is for patient with active disease, light blue is for IBD patient in remission, and the purple is a control arm. And we expect that patients with IBD who have active disease would have work limitation. But also look at patients in remission. 62% of them have work limitation, and it's mainly due to fatigue. And this is often a symptoms our patient report even when they are in remission, and it's probably multifactorial. So it's important to take that into consideration when we're assessing the patient. How much of the fatigue is going on? Is it related to anemia? Is it related to malnutrition and nutrient deficiency? But even after correcting for these factors and putting the patient in remission, fatigue can persist and really affect the patient capacity to perform at work. Then if we look at missing work, absenteeism, as expected, patients flaring cannot make it to work at a higher rate than patient in remission or the control. And the reason are often needing to go see the physician or going to the ER or being hospitalized or simply having GI symptoms that make it uncomfortable to go to work. And then in the middle columns, we'll look at the presenteeism. So just as a reminder, presenteeism meaning going to work when you're not supposed to go to work because either you're sick or you're working overtime to catch up on work. And look at our patients with IBD and active disease. 94% will make it to work when they're sick or spend extra hours at work to catch up for things compared to the general population. So our patients with IBD, probably because of the chronicity of the illness, are feel the burden of not missing work and still make it to work in order to, pay the bills or being at work or not have or not lose their jobs from missing repeated work days. So it's very important to think about this in our attempt to treat our patient, that we need really to give them the effective therapy quickly, early, like Dr. Ha mentioned, because our patient cannot afford missing work or being at work when they're feeling ill and they should be seeing their doctor. So in order to minimize absence from work or being at work when you're feeling ill, it's very important to treat our patient appropriately and early. The other thing to discuss with a patient when we're offering the option, we're talking about, should we do azathioprine, anti-TNF, Vedo, ustekinumab, and some people say, well, I don't know, that it's all these options. Why would it be different from one patient to another? So you can only imagine for patients, when we're offering all these options, it's very hard for a patient to make an informed decision if we don't go over first, what are the goal of the patient? What do they want from the treatment? What are their goal of care? And for us to explain clearly what each treatment can do for them and really have this conversation to help patients make an informed decision on what kind of therapy they need. So this is a nice study looking at IBD patient and particular Crohn's patient and asking them, what do they value in a treatment? What do they want from a treatment? And of course, our patient want to feel good quickly, short-term improvement. They want to feel good long-term. They want to be doing well, not missing work and being able to take care of their family, their kids, themselves, etc. They are concerned about the lymphoma risk associated with certain therapies. And they are interested to know how frequently they need to take this medication and how they're taking this medication. Is it oral, IV, or sub-Q? So it's important to ask the patient these questions to have an open conversation and see what the goal of care of this patient is and make sure that our goals of care are aligned with the patient. And this really brings me to one of my, the thing that I talk the most about is effective communication with the patient, really discussing the risk and benefit of the option to find what is right for this patient. Have open question. What question do you have? And go over these questions without rushing the patient. Really have attentive listening to the patient concern and be able to answer those questions and really leave a kind of an open door policy. Have a follow-up visit for further questions. Send me a message or an email and let's discuss and really have a holistic approach to the patient and go into details about their concern and into details about what medication, what every medication, class of medication can do or cannot do for them, what are the risk and benefit, and find the right therapy for them. So, following Tina's presentation and point into starting early biologic to achieve early remission, decrease the need of steroid, decrease the need of surgery, and following the discussion that we have, that it's really important to monitor our patient and see how they're doing, and to prevent further complication of Crohn's, I really wanted to review the data of the CALM study led by Jean-Fred Colombet. So in the CALM study, we took patients with moderate to severe Crohn's disease who have never been on a biologic or immunosuppressive therapy, immunomodulator, and patients receive induction dose of adalimumab. And then if they were not doing well, they moved to adalimumab from every other week to every week. And again, if they're not doing well, they move from adalimumab every week to adalimumab every week plus azathioprine. So what does not doing well mean? There were two groups: the clinical management group, where the change in therapy was driven by patient symptoms. If the patient came back and said, I'm having diarrhea again, I needed to use prednisone again, then treatment were adjusted accordingly. And then the second group is a tight control group, where treatment change were based on either clinical symptoms, or if the markers of inflammation such as fecal calprotectin and CRP were increased, independent of the symptoms. So if the patient has been doing well, come to clinic, have 2 nice bowel movements per day, but their fecal calprotectin was higher than 250 or CRP higher than 5, then in the tight control group, change were made accordingly, going to the next step. So what did we find? So we found that the tight control group proactively adjusting therapy based on objective markers of inflammation and not only on patient symptoms had a better overall outcome at week 48. Patients in the tight control group had higher incidence of mucosal healing and were steroid-free and achieved steroid-free remission at every visit. Tight control group also had fewer hospitalization and longer period of remission. There was additional cost with the tight control group because of the monitoring in the labs, etc. But overall, if we look at the overall pictures, and this was looked at in a study by Paniccioni, the tight group overall, the tight control group was a more cost-effective strategy overall by saving on hospitalization and not being in remission and physician and ER visit, etc. Keeping a tight control of Crohn's disease allow not only for better management, less steroid use and mucosal healing, but overall was a more cost-effective strategy. So let's go over the therapies. We had a lot of questions coming in. Why would you choose anti-TNF or Vedo or ustekinumab? So let's go over the data of vedolizumab and ustekinumab, the newer biologic in Crohn's disease. So vedolizumab induction study, the Gemini 1, after two infusion of vedolizumab at 0 to 2 weeks, people were assessed at week 6, and clinical remission was achieved at a higher rate in the Vedo group compared to the placebo group. How about maintenance? Vedolizumab given 300 milligram every 8 weeks. Our patients with Crohn's disease on vedolizumab achieved clinical remission and response at the end of a year at a higher rate than patients on placebo. And more importantly, they achieved steroid-free remission at the end of the year at a higher rate, 31% compared to 16% for patient on placebo. How about ustekinumab? Ustekinumab had 2 induction studies, Unity 1 and Unity 2. I want you to focus on the red bar is ustekinumab at 6 milligram per kilogram of weight-based dosing. This is what we use in practice. The blue bar was another dose at 130 milligram, a stable dose. And the gray bar is the placebo. So patients receiving ustekinumab had a higher rate of clinical response in Crohn's disease after 1 infusion of ustekinumab, the first dose of ustekinumab. And this response didn't have to wait until 8 weeks. You start seeing this change, where we separate from the placebo response as early as 3 weeks. So as early as 3 weeks, you can tell your patient with Crohn's disease they're going to start feeling a difference, and their symptoms are going to start improving. How about clinical remission? Again, ustekinumab has been shown to have a higher rate of clinical remission in Crohn's disease compared to placebo. Compared to placebo after the induction dose, after the first IV dose. 20% of patients were in remission at week 8 in Unity 1, 40% were in remission at week 8 in Unity 2. So again, after one infusion of secukinumab, 20 to 40% you can expect remission at 8 weeks, but this remission will start much earlier, as early as 3 weeks after the first infusion. How about during maintenance? With secukinumab at 90 milligram every 8 weeks. Again, we're seeing a difference between patient on the treatment group versus the placebo group in terms of clinical remission, clinical response. And those who were in remission after the first infusion of secukinumab, 66% remain in remission at 1 year. So those who have a good response or go into remission after the first IV infusion, you can be confident that they're going to do really well with maintenance on secukinumab. Okay, so again, this brings us back to what do we choose, etc. And in Mateo, if we're not going to choose anti-TNF, which one should we choose, Vito or secukinumab? Well, this is a little bit of a different study. This is a study that was at this point in an abstract form, looking at patients who failed anti-TNF. And one of the questions we had in our audience, if you fail one, what's next? And if you fail the second one, what's next? So hopefully this study can help answer some of these questions. So if you failed anti-TNF and you go on either vedolizumab or secukinumab, there was a higher chance of achieving steroid-free clinical remission and biochemical remission if you're on a secukinumab. These are retrospective studies, so it's hard to tell if there was a difference in dosing, difference in patient selection, etc. But in patients with Crohn's disease who have failed anti-TNF, probably the next best choice would be secukinumab before considering vedolizumab. I would still consider vedolizumab in specific situation, and that is why it's important to look at the entire patient, their age, the comorbidities, their risk of infection, their preference with injection or infusion. So there's a lot of factors to take into consideration when choosing what is the next step after anti-TNF. So let's go back to Mateo. So Mateo is our 33-year-old Hispanic gentleman. He's a social worker. He has a high risk for TB exposure, has moderate to severe Crohn's disease that is really affecting his capacity to go to work. What would be the next treatment for Mateo? Again, azathioprine, anti-TNF, secukinumab, vedolizumab, we still don't know. All right, so again, we see again a drop in azathioprine, and Tina, I would like to hear your opinion on that. How often are you starting young men on azathioprine as your first therapy?
No, I'm not doing it very often anymore. It's not to say that azathioprine doesn't have its role. For me, its role has actually now more been relegated to an adjunct, particularly now since we have biosimilars, if there's an issue of cost and access. And I think biosimilars has helped out with increasing access. But for a young male, azathioprine wouldn't be my first choice. But I do think that the biologics are very reasonable. I think there's certain factors in Mateo's history that would kind of sway us towards one versus the other.
I agree. I tend to use azathioprine now in combination therapy or to boost the biologic level or prevent antibody or fight antibodies. But in a young man, there's a potential higher risk of lymphoma in young men, especially hepatosplenic T-cell lymphoma. And also, azathioprine takes time to work. So we're putting our young patient prolonged exposure of steroids, and we do have now more effective therapies. And so in terms of risk and benefit, I feel like the risk of lymphoma is mainly associated with azathioprine. So I try to avoid that in my young men. So azathioprine is not my first choice, and it seemed like our audience are not favoring azathioprine. And anti-TNF would have been great for Mateo, but he had a recent exposure to TB. He works with immigrants. So with anti-TNF, we get concerned about reactivation of TB or getting extrapulmonary TB and severe TB. So I think in Mateo, anti-TNF would not be my first choice, again, because of this piece of his medical history and social history. So then we go to secukinumab and vedolizumab. Do you have a preference, Tina? How do you approach that as a first biologic?
So as a first biologic, I think that if he, not factoring his work and the exposures, looking at his disease severity on his colonoscopy and just time of onset to action, and also some of the factors that he's concerned about. Presenteeism, he doesn't want to miss work. Using an agent that's one infusion followed by injections, he can time the injections in his maintenance therapy to be so that he doesn't have to miss work. Oftentimes, we don't think about this with infusions, but it's not as though people just get time off. A lot of my patients, they use up all of their FMLA. They use up all their sick days. They even go into their vacation days because they need to get infusions. And especially knowing that he has deep ulcers, he may be somebody who we may need to adjust the dosing to as frequently off-label as every 4 weeks. So that's 12 days out of the year. And many infusion centers aren't open nights and weekends. So factoring all of that, I would actually, for Matteo, lean more towards ustekinumab. The question of the TB exposures are there, but the signal for TB and ustekinumab, although it's not zero, it's not as strong as with the anti-TNFs.
I agree with you. And I think you highlighted very nicely how, the choice of therapy has to be the therapy that we feel is going to be the most effective for the patient and the safest for the patient. And every patient is different depending on their social history and medical history, et cetera. And then patient preference is very important. I have some patients who would not inject themselves for anything and prefer to come and have an infusion. Or I have patients where there's a issue of maybe compliance, or I can get a chance to see them every time they can get infused and give them some more positive feedback. So the choices really of which therapy are multifactorial, but I agree with you on this one. With the severity of his symptom, wanting to get him better, vedolizumab works very nicely for Crohn's disease, but has a delayed onset like we saw in the induction trial. It takes time for it to work. At the end of the year, it's working very nicely. But in somebody like Matteo who cannot afford to miss work and wants to get better quickly, I think ustekinumab would be a good choice here too. Absolutely, I agree. All right. So, a lot of our, some of our audience actually asked, Tina, what's next? If a patient goes through this whole, biologic and doesn't get better, what's next? Are there things on the horizon? And I think, before we, I would love to hear your thoughts and get a sense of what's coming up soon. I think the important message also is always to optimize a therapy before moving to the next one. I think I see two behavior with biologic, either a reluctance to start biologic, like you showed, Tina, like a lot of patients don't get the biologic that they need early in the treatment. It seemed like for some people, they are saved until, people are sick or they failed multiple courses of mesalamine, azathioprine, and steroids. But also there is kind of a biologic turnover that's really high. So I see these two behaviors that are something that we should really avoid. We should start biologic early, but then if we don't achieve the response that we want, and again, it's not only the clinical response, but also biochemical response, endoscopic response, it's important to optimize what we have. And you mentioned, escalating dose, escalating frequency. These are off-label use, but we know they are effective in order to achieve remission in patients with more severe disease or who tend to, eliminate, have a higher clearance of biologics. So it's important to optimize before moving to the next biologic, because then it's very easy to go through 2-3 biologic and be left without an option. Thankfully, there are a lot of options in the pipeline, but it takes time for trials to be completed and for FDA to approve things. So it's important to be mindful when we're moving from one therapy to another. But I would love to hear, Tina, your thoughts about what's coming up in the pipelines.
Yeah, and I couldn't agree with you more. And I think that that's what the CALM study underscored, was when we're talking about treat to target, we're talking about monitoring at set intervals so that you don't leave somebody on a strategy that isn't working. And so with the treat to target, the beauty of that design was about optimization, not immediately switching classes, which underscores your point. Because over the last decade was great in terms of IBD. We have multiple new MOAs that we didn't have before. And I think the next decade will also be as great in terms of all these new agents, but it does take time. There are a number of agents that are in the pipeline that are currently enrolling in phase 3 studies, and they encompass a wide variety of mechanisms of action. Some we're a little bit familiar with, some not so much. So it remains to be seen how truly effective they'll be in the phase 3 studies. But for example, we're familiar with integrins because of vedolizumab, but there are additional anti-integrin agents with slightly different MOAs that are in the horizon, such as etrolizumab and abrimlimab. One of the keys is they become increasingly harder to pronounce. There's also an anti-MAdCAM, a monoclonal antibody called ontimalimab, and a number of anti-IL-23 agents, such as guselkumab, mirikizumab, risankizumab, and brazikumab. You may be familiar with some of these because they're already on the market for rheumatoid arthritis or psoriasis. There's also the sphingosine 1-phosphate receptor modulators, the S1P1s, like etrasimod and ozanimod. Some of these may sound familiar because some of these mechanisms are FDA approved for multiple sclerosis. And then there's the selective JAK inhibitors. You may be familiar with the tofacitinib data, but that's a non-selective JAK inhibitor. There's a JAK1 inhibitors called upadacitinib and filgotinib, and other JAK mechanisms that are also in the horizon. But let's delve a little bit more as an example into one agent that's currently enrolling in phase 3 studies, etrolizumab. This is data from the phase 2 studies, so we're excited and looking forward to the phase 3 data. But across the board, it shows that in the 2 different dosing strategies, 105 milligrams every 4 weeks versus a more intensive, higher dosing 210 milligram strategy. Both were superior to placebo for symptomatic remission, defined by clinical endpoints at week 6, 10, and 14, but also objective parameters such as endoscopic improvement at week 14. It was well tolerated and resulted in clinically meaningful improvement in patients with moderate to severe disease, akin to as well as vedolizumab is tolerated, but etrolizumab is slightly different in that it's a monoclonal antibody to alpha E.
Thank you so much, Tina. It looks like we have different agent on the horizon, and I think the goal will be ultimately to personalize our care and find ways to choose the therapy that would work for our patients, maybe using the genetic microbiome, other factors that will help us predict which patient will respond to which drug best and choose the drug accordingly. So I hope we were able to achieve some of the SMART goals that we set for ourselves, and then we'll take some questions. Really, our goal today was to raise awareness among the IBD care team about social determinants of health that might impact the care and outcome of racial and ethnic minority patients. It's important to take action early and treat with biologic and monitor throughout the course of therapy and to achieve mucosal healing and to prevent long-term complications. Long-term remission is best positioned for patient and to improve their functioning, their quality of life, and to allow our patient to have a full life like they expect it to be, and educate our patient about their disease to empower them to be active participant in the management of their IBD. I think the communication is key between physician, nurses, the entire IBD team with the patient.
And with that, I would also add the caregivers as well, particularly if we're talking about racial and ethnic minority patients where the familiarity with the terms Crohn's disease, ulcerative colitis, immunosuppression may not be there. So it's very important to never forget the caregivers too.
I absolutely agree with you, Tina, because I sometimes feel that I'm discussing things with a patient and the patient might go back to their family members and a whole different discussion happens. And I don't want my patient to be under that pressure of making a decision on therapy and having the pressure from family members of not taking therapy or considering alternative medicine or feeling that this is going to pass because of the unfamiliarity and not knowing what these therapies are. So I think it's very important what you just said is that the communication should be with the patient, but also I often offer the patients, do you want us to have this discussion with your family? And now with televisit, it's actually even easier that we can have multiple people log in at the same time. So I'm able to answer those questions and the concern that the family member has. And it's not the burden on the patient to use unfamiliar words and unfamiliar terms and not really still like learning about the disease. And so that the patient would have a supportive environment at home and not an environment that might deter him from getting the right therapy. So I absolutely agree, caregivers should be involved because this is a whole new world for patient from any ethnicity and race, but even more so in cultures where this disease was unfamiliar up to recent years. Absolutely. All right. So we're going to take some questions here. There's so many questions coming in. Okay. What's a reasonable timeline to expect clinical response in Crohn's and UC when using vedolizumab? When should we decide if a patient is a non-responder? Do you want to take that, Tina, and then I can answer too?
Yeah, and you know, I don't think that the treat to target model is specific to any particular MOA. So even though the CALM study looked at adalimumab, you can extrapolate that strategy to any of the treatments. So I always tell patients that we expect to have some form of improvement within 12 weeks of starting it. And if we don't, it's not necessarily that the mechanism or that agent isn't working, but we have to understand why it isn't. Is it because there's some other process that's going on? Is it an issue of adherence or cost or access? Or is it an issue that it's particularly, it may just not be the right agent? So that treat to target strategy is just a concept that you have to set reasonable goals within a reasonable time frame to expect a response. Now, we're not talking mucosal healing. We're not talking about steroid-free clinical remission by week 12. We're talking, in my practice, I'd like to see at least a 50% improvement in their primary clinical symptoms. It may not be the PROs of abdominal pain and stool frequency like is in the Crohn's disease trials, but I will always ask them, what is the one symptom that bothers you the most? And then I say, well, this is something that we have to see that is better at week 12, in addition to objective markers. I always show them their scope pictures. I show them their histology. I show them abnormal labs. And these are the deltas that I follow at week 12, no matter what the mechanism is.
I agree with you. We have to see some response to then decide whether we need to continue the therapy, adjust the dose and the frequency, like in the CALM trial, or do something different. And vedolizumab, I think the question is, in Crohn's disease, because of the slow onset of action, it's important to discuss this with the patient and have a plan in place. So if symptoms can be controlled with some budesonide or low dose prednisone until we get to the first or maybe the second dose, I would do that and then taper down according to the response and using also objective marker and clinical symptoms.
So in Gemini too, the curves really did separate by week 10. So still following that model. And so essentially by the time they get their first maintenance dose, they should be feeling better. If they're not, then rethink.
Absolutely, absolutely. By the first maintenance dose, we should know if we're in the right direction, and then you can decide if they are in remission, keep them on every 8 weeks. If they have a response, but you need to do better, you can adjust frequency of therapy and take it from there. But there has to be a response, and we have to kind of, for patients who have been on anti-TNF and got that dose of infliximab and felt better the next day, it's important to give realistic expectation when we're using therapy that are slower in onset. And I always remind my patients, if this therapy works for you, that is fantastic, because Crohn's disease or IBD is a long-term disease. So it's a marathon, it's not a 5K. So we want to get better. As long as there's a response, we can get you to that final stage of being in remission. If there's no response at 12 weeks, then we need to think about other mechanism of action. After ruling out precipitating factor, C. diff, infection, other potential etiology, and that's where a biological marker also are so important. We all have seen patients where their CRP and fecal calprotectin normalized, but they're still having abdominal pain and diarrhea that could be due to IBS, lactose intolerance, or other reasons, and we might change therapy for the wrong reason. So it's very important, like you said, to follow clinical symptoms, but also biologic marker of inflammation to get a sense of where we're heading.
Yeah, and what I also say is, during that first 12 weeks, it's not just about the biologic or the agent that you choose. I always say that during that first 12 weeks is the time where you optimize other modifiable variables too. So that's where you have them meet with the registered dietitian, and you actually look at their diet and make sure that nutritionally that you've repleted things like iron, zinc, B12, D, get their physical status, conditioning better, and look at their sleep patterns, and work on other lifestyle measures such as stress management. These are all things that can be done during the first 12 weeks, because the expectation shouldn't be that one agent is going to take care of everything, but it's a whole process that involves the entire body.
Absolutely. We have a question about, what diet should we have for IBD? And I talk a lot about diet and nutrition to my patients and encourage them to avoid processed food and added sugar, because there has we don't have solid data, if you want, to tell us that processed food or sugary food, etc., increase the risk of IBD. But with the data that we have, how first generation immigrants coming to this country and the risk of IBD increase suddenly and become very similar to the US population, genes don't change that fast. So it has to be something in the environment. And what changes is our lifestyle, the fact that we're not active, we're not walking to work, we're not doing manual labor, we're not, walking to places. So we're sitting often in front of our laptop working, but also diet. And unfortunately, our diet in the US is low in fiber, high in red meat, a lot of added substance, processed and ultra processed food, added sugar. So I do talk about diet with my patients. I do refer them to a nutritionist. And nothing makes me happier when patients tell me I stop eating Pop-Tarts and hot dog and I'm having fish and some cooked vegetable. But it's also important to be patient. When you're flaring, the things you tolerate are going to be limited than when you're getting better. But diet absolutely is an important part of the process. Repleting iron deficiency, absolutely an important part of the process for allowing mucosal healing and fighting the fatigue and feeling better. Absolutely. Comprehensive care is what we need. How about smoking marijuana? Is it as bad as tobacco or e-cigarettes? What do you think?
Well, the honest truth is, I think it remains to be seen. A lot of people, like to refer to a few limited studies that looked at the impact of cannabis in terms of improving Crohn's disease, more symptomatic than truly objective or mucosal healing related measures. I think that in limited doses, is it that much worse is it a lot worse or comparable to cigarettes? Probably not. However, there is a potential impact of cumulative usage of marijuana. There's cannabinoid hyperemesis. There's it impacts your mental faculties. So it could be contributing to some of the issues that you're trying to treat. But what I think the main thing is to just be transparent, have an honest conversation about it with your provider. Will it help with nausea? Absolutely. Sometimes it can help with nausea. Is it better than being on narcotics? Sure. In limited doses. That being said, it should never be a replacement to your primary treatment, because you never want to just address an effect, you want to address the cause.
Absolutely. I think we're going to take one more question, and that's a topic dear to your heart also, Tina. What are the effects of aging on IBD?
Oh my gosh, do we only have a couple of minutes?
Somebody who knows you well must have put in this question.
So much. I think it's a very fascinating topic. And, to keep it brief, there's two different types of impact of IBD on aging. There's late onset IBD, which means diagnosed later in life, typically Medicare age after 65. And it was poorly recognized, kind of just like it was thought that Crohn's and ulcerative colitis couldn't happen in Hispanics and African Americans. Now we're also seeing an increased incidence. The elder patients are the most rapidly growing population within our country. So I think that when we think about the elderly, we have to take a step back and really evaluate what are our goals of care here, because it's not about numeric age, it's about functional age. So it's looking at their risks, their functional status, sarcopenia risk, which is their muscle mass, their ability to tolerate inflammation, their risks of infection, comorbidity, and in all honesty, you have to think about things like cancer risks and lifespan. So it's a lot more of a nuanced, tailored conversation where you're probably less willing to accept risk in order to achieve a certain type of efficacy. So the question is, for somebody who has comorbidities, do you need to achieve the deep histologic remission like you would a 20-year-old who otherwise is doing well and has 70, 80 years more to live? Probably not. But do we want to keep them on chronic steroids? Absolutely not. So it's definitely a lot more nuanced.
Absolutely, absolutely. All right, there's one more question. It's too good to pass out, and then we'll stop to let people have dinner and let you go. If you have a patient on anti-TNF, or I guess on any therapy, and their disease is progressing, but they are not symptomatic, what do you do? And I think this is a very wide question because, what is asymptomatic? I often see patients with strict-during disease and they tell you they're feeling fine, but actually if you ask them in detail, they're restricting a lot of food, they're not eating fruits and vegetables, they're not eating nuts, they sometimes feel bloated, they sometimes vomit. So it's important to really define what is asymptomatic and what is disease progression. If your patient had small bowel disease, for instance, on colonoscopy, inflammatory type of disease, and the year after they have a stricture, that's a progression and something else has to happen? Or is it that when anti-TNF was started or any other biologic, was it already too late? Was it already progressed? Do we already have a stricture? And is it better if the patient is asymptomatic, is one way, we can observe, in my opinion, if a patient is symptomatic, then surgery makes more sense than trying to change therapy. So I think this is a wide question, but I'm just wondering, let's say you just see few ulcer, and then the year later you see more ulcer, deeper ulcer while on the therapy. What would you do? How do you optimize? Do you change? What do you do, Tina?
Well, I agree with you completely. And even though we're talking about Crohn's disease, I think it actually translates into Crohn's disease very well. But we all have heard of the UC Normal study, which was through David Rubin's group, which basically tells us that we're not actually very good at identifying how well patients are doing. So if they're progressing and they're asymptomatic, I agree with you. Oftentimes they're not really asymptomatic, and it's because we're probably not asking the right questions, or they're not telling us the true symptoms. So that's an issue with our means of communication. But if I do see disease progression, I take a step back and ask myself, okay, why would this be occurring? We have to think about adherence. We have to think about therapeutic drug monitoring. Is there an issue of immunogenicity, or is the tank simply hitting empty before the next injection or the infusion? And so this is where the conversation about true clinical symptoms, doing an objective assessment, doing therapeutic drug monitoring when available, and then really discussing what the pros and cons of optimization are. And also access, because certain types of optimization aren't necessarily available for everybody. And so, for example, if the question is, somebody was doing very well on ustekinumab, and now they progressed and they have a stricture with an inflammatory component, but they simply can't get optimized ustekinumab, their natural history is likely that they're going to need a surgery. So they may do better with a primary surgical resection and then continuing with their post-op ustekinumab. So I think, again, nuanced, but we really have to work on our communication to understand why the progression occurred in the first place, and then investigate for immunogenicity and therapeutic levels.
Absolutely, I agree. All right, we're going to conclude our session with this last question. And please remember to receive credit, CME and CE. Please follow make sure you request them, make sure to fill your ABIM ID number and date of birth, and CMEO will submit your credit to ABIM. Tina, I want to thank you for this wonderful Monday Night IBD. Maybe now I can convince you to join the Twitter version of this.
I know. I need a Twitter.
I know we converted you to our format.
Thank you for having me. This was great, and it's always wonderful to talk with you.
That was fantastic. I think we learned so much more than that our goals were, but I hope we leave everyone with many important points about recognizing IBD in minority, recognizing that there are barriers to care in minority and in patients of low socioeconomic status that we need to address. And we need to have a communication with our patient, their caregiver, their family, to achieve the best care we can have for our patients.
And fund more studies looking at them.
Yes, I think the future is there, looking at more studies. And I know, like you said, Dermot is looking at this, and I promise him we'll give a shout out to his study looking at the genome and genotypes in minorities with IBD. So if you have a patients from any non-white ethnicity, please make sure to reach out to
Doc IBD.
Here you go. Perfect. Have a good night, everyone.
All right. Thank you. Have a great evening.
Again for joining me.